I come from Toronto. This is what Toronto looks like up at the top here. Very beautiful city. I hope you all visit at some point. Not as beautiful as Palma, of course, but it's very nice. We've seen over many years now. I think I've been seeing patients with 22q11.2 deletion syndrome for about 20 or more years. I think quite more than 20. And we've seen and follow 205 adults with this condition. On average, their age is in about the mid-30s now. But we've seen everyone from age 18. We see them. That's when they start being an adult, up into the late 60s. They mostly come to see us at least for our research study, because they have heart defect. Or because they have psychiatric or behavioral problems and people want help with that. And some now are coming because they were found to have 22q because they were a parent of an affected child. So you just have to keep in mind a little bit when anybody is talking about this condition, and I've seen a lot of patients, that they come from somewhere. So you get a certain view of people. And Dawn, I don't think you mentioned the 5 blind men and the elephant, but this is the emblem of, for 22q11.2 deletion syndrome, is of an elephant and 5 blind men. What is it? They touch the foot, it's a tree trunk. They touch the side, it's something like leather. They touch the tail, and it's a brush. It's like a broom. And they touch the trunk, and it's all wrinkly, and it's like a hose. So that's what 22q is like. So it depends who you see and who you get used to seeing with this condition. That's what you think of 22q, but everybody's a bit different. So we follow patients long term. So if you see babies, then you're concentrating on the birth defects and the feeding difficulties and the development. If you see children, you're concentrating on the speech delay and the language and the palate problems and some attentional and emotional and starting behavior problems. And if you see adults, like we do, this is our specialty, is in adults, then you're concerned about how well the person is able to function socially and work and school. The learning difficulties, of course, always come into play. Psychiatric illness is very important, and all the way along, treatable medical problems. So that's the focus more for adults. So when we went backwards and forwards in time with the adults that we have seen, the 7 most common features over the whole lifetime of the person, from birth to when we saw them in whatever age they were. Intellectual disability, of course, is very common, but a big range, which I'll show you. Low calcium, very, very common. In fact, this is out of date now. It's about 80%. So 4 in every 5 people with 22q11.2 deletion will, in their lifetime, have hypocalcemia related to hypoparathyroidism. So it's very common, and this is why we recommend vitamin D and calcium supplements for everybody with 22q. Scoliosis, curvature of the spine, minor, not usually needing surgery, only in a minority of people, is quite common. The palate, of course, we already heard about, is quite common. Recurrent seizures, some of them are to do with the hypocalcemia, with the low calcium, quite common. And recurrent pneumonia is mostly in children. So that's something that many people grow out of, it would seem. Obesity, well, it's a problem, especially in North America, what can I say? But it becomes more common, particularly in adolescents, in 22q. And thyroid disease is by the time you get to adults. So I was trying to listen to the translation, which was an excellent talk of your talk. So if you look in children, it's kind of not very common. But once you get to adulthood, and this is fairly early onset, it's not like you're getting it at age 40, 50, which is when it's typically in the general population. This would be much earlier onset in the 20s and 30s often, or in childhood. 1 in 4 to 1 in 5 patients will have, 1 in 5, 1 in 4 patients will have a thyroid disease. So this is something that we are always on the lookout for because it's easy to treat. Gallstones, very common in our patients. Doesn't come into the criteria. You don't think 22q gallstones, but that's something that's really quite common. The heart defects we won't talk about because we know about that. But it's a chronic disease. So the only point I'll mention about the heart defects is that it's something, if you have a serious congenital heart defect, it becomes a chronic disease. Even if it's treated right at birth, you have to be followed the rest of your life by a congenital cardiac team, by somebody, by a specialist cardiologist who knows about this because you may need further surgeries, and it's really good to be followed along for that condition. I work with a wonderful team in Toronto, one of the best in the world for adults with congenital cardiac disease. Hearing deficits are really quite common in this condition, and probably more so in adults. And asthma, of course, is quite common in the general population, but you have to consider it because a lot of patients are on pumpers. So this is a key thing that you've heard now over and over again over the course of this day, is that this is a very variable condition from one person to the next. There are similarities, but there are big differences. So this is a study, again, that we did a number of years ago. So on average, taking the most common 45 features that you would need medical attention for that are associated with 22q, you can see from this graph that some people are kind of lucky, they only have 3. Other people, perhaps not so lucky, one has 22 features of the 45 that we studied. The median number, so the average number, was 9 clinical features needing attention over the lifetime per person. But that's only the average, right? So there's a big range. That's just the number. The severity of each one of those features is also variable from person to person. It's not an easy subject sometimes to talk about, but everybody dies. We all die, right? That's death and taxes. Those are the 2 for sure things in life. So we have studied long-term outcome in 22q1.2 deletion syndrome, and we have found when you compare to the unaffected brothers and sisters of people with 22q1.2 deletion syndrome, that on average, again on average, the person dies quite a few years younger than the sibling, than the brother or sister in the same family. On average, in our group of patients, which you have to remember where our patients came from, it's about age 45, 44, 45. But that's on average. So the range was 18, which is very unfortunate. Complication of a procedure at age 18, up to age nearly 69 years old of a stroke, in somebody who smoked the whole way. So, but that's our experience so far with this condition. There was no one cause of death. It was very variable. The most common cause was a sudden cardiac death, but not necessarily in individuals who had a congenital heart defect. So this is something that we certainly want to study more, and there just didn't appear to be any other features that we could tag to this or figure out. So for adults, one of the most important expressions that we're concerned about following adults along are the neuropsychiatric expressions. So these are brain disorders, and I'm going to go through those for you because you've already heard a bit about neonatal seizures, which are usually due to low calcium, and of course the developmental delays and autism spectrum and attention deficit, and those are things that start in childhood. So the intellectual level, first of all, just the background, it's the same in adults, the same range that we see in adults as it is in children. So there's a fairly substantial minority who have an average intellectual level, and then about half have what's called borderline, just a little bit under that, and then the rest have levels of intellectual disability. So treatable psychiatric illnesses in adults, what we did was we thought, okay, so we see a lot of people coming to us because some of us, or like myself, I'm a psychiatrist by training, they're coming just to see me because they have behavior problems. So we won't look at those people. We will only take the ones from the cardiac center because the cardiologists, they're not seeing people because they have nerve problems. So in that, because we wanted to get a true idea of what the rate of the frequency of different psychiatric conditions was. So, and we wanted to compare, okay, because psychiatric illness is very common in the general population. So we have on the right-hand side of the slide, we have the population prevalence. So this is, it's an American study, but you know, it's probably about right. Nearly half of the general population has, at one time in their lifetime, as an adult, will be found to have a non-psychotic disorder. So it's a common psychiatric illness, basically. The next one down is schizophrenia. About 1 in 100 people have schizophrenia in the general population. In 22q, it's 22%. So this is the highest increased risk, but the number of people with schizophrenia is actually less than those with any other kind of treatable psychiatric illness. Depression is about the same level as in the general population. Anxiety disorders, which you've already heard about, are more than expected in the general population, about double the rate. And then the rest, it's about the same as in the general population, maybe a bit more, but it was quite a small sample. So these look to be, you know, relatively correct. But the main message here is psychiatric illness is quite common in the general population. Some of them are much more common in 22q. So what is schizophrenia? Like I said, it's about 1 in 100 people. About 3 in 100 people will have what's called a psychotic illness. What does psychosis mean? It means being out of touch with reality. And Jacob and James already talked a little bit about this. It's not to be confused with being a criminal or psychopathy. It's not to be confused with having a split personality, which is what Hollywood tends to call schizophrenia. So it's none of those things. It's an illness that tends to strike the young, usually in the teens to 20s, but can be in their 30s. The signs and symptoms include changes in thinking, so that's, you've already had to describe hallucinations, which would be hearing things when there's no sound coming into the ears, seeing things when there's really nothing there, or delusions, which are false beliefs. So you believe that you are being followed when you're riding your bicycle, but nobody is following you, something like that. Behavior changes, usually social withdrawal, even from the family. So isolating in the room, not even coming to eat dinner, something like that. Disorganized behavior, doing things completely out of character for that person. Completely, you cannot understand why are they doing that. It's just beyond your ability to understand. And changes in emotions. It's often a depressing disease. People get more anxious. They're irritable, cranky, and sometimes also quite commonly, they will have less emotional expression than they used to have before. So it's sort of a kind of a closing in, as well as sometimes being a bit more disorganized and agitated. It's usually lifelong. It's a serious illness. There's no question about that. It affects functioning and work and school and relationships, but it's treatable. And we know what to do. We know how to diagnose it. We know how to treat it. So the mainstay of treatment are antipsychotic medications. We have a whole range of choices of these medications: pills, liquid, injection. Lots of choices. They're not perfect. No medication is for any condition, but they do work, and they're pretty good, and support and rehabilitation are the other mainstays of treatment. But without the medication, the person has a 90% chance of going back and having the symptoms again within a year. So there are no lab tests. There's no X-ray. There's no brain imaging that can say this person has schizophrenia or this person does not have schizophrenia. It's a clinical diagnosis. It completely depends on understanding how the person used to be and how different they are now, how changed they are now, and the signs and symptoms over time in their presentation. So I just want to emphasize that that's a very important illness to diagnose in this condition because it's about 20 times increased risk than over the general population. But mood and anxiety disorders are actually much more common and very treatable with standard treatments. Excellent range of treatments. I love treating depression and anxiety. They're really good, and there's lots of options, not only with medications but also with other forms of cognitive behavioral and other treatments. And then we also have an association longer term with Parkinson's disease in a small subset of patients, but it is an increased risk for young age and onset Parkinson's disease. Perhaps the patients that we've seen have developed this illness or had it diagnosed when they're in their 40s. So just again to reiterate that these are treatable illnesses. They're common in the general population. We know what to do for them. And the most important thing is to diagnose them early with an expert and get the effective treatment to the person as soon as possible, because that improves your outcome and your functioning. And there's lots of other things that anyone can get, and people with 22q are no exception. So what contributes to that expression? The learning disabilities, we've already heard about this. You need to make sure that when you're making a diagnosis, this is why you need to see a specialist, is not just the learning disabilities on overload. So not just like the imbalance, I think this is the word that everybody's using today, between the expectations and the person's abilities. So that it's not just an overload for that person. You make a diagnosis based on the clinical signs and symptoms. People with 22q also can have, and you may recognize this, often comes on in teenage years, so adolescents and adults, emotional outbursts. So they're like a storm. They're fine, then, they misplace their iPhone or something, and boom, you're screaming, shouting, throwing things, big tantrum, and then it's over. And then they're all fine. You're kind of, oh my goodness, what happened? But those sort of emotional outbursts, those are more common with untreated or undertreated psychiatric illness. So if the person has an anxiety disorder and it's not treated, that's something that you need to take into account. And certainly with psychotic illness, with schizophrenia, that you can see these outbursts as well. They're not seizures, but they kind of seem like it because they come out of nowhere and boom, and then they're like an explosion and then it's gone. Other neurological conditions, you have to make sure that what you're seeing also is not a seizure disorder, is not a form of epilepsy. That's very important. And the contributions, especially with respect to anxiety disorders, but also depression and even psychosis, that it's not due, that what you're seeing, the changes, the behavioral changes and the mood and sleep changes or whatever, are not due to low calcium or thyroid disease or other endocrine disorders. Also, if the person, their brain is starved of oxygen, so for example, if they have something like sleep apnea, so they have during sleep, the back of the throat actually closes off and the brain is not getting oxygen. In fact, the person is not breathing for a period of time. That also is not good for the brain and can make people quite irritable and have sleep disturbance and really be quite agitated and show signs. So you have to make sure that that's not contributing to the symptom picture. So what can we do? So we have an increased risk of psychiatric illness. What can we do? So lifelong, these are sort of, well, it would be good for all of us, right? Good nutrition, physical activity, those are good things. Avoiding alcohol and street drugs, also, that would be particularly good if you are vulnerable to developing psychiatric illness. Genetic counseling so that you're prepared. This is very good. So if you know that this is a risk, then people are looking out for it, the signs and symptoms, so that you're going to catch it early and get the best treatment and the best diagnosis as soon as possible, and optimizing that psychiatric care and making sure that it's steadily provided for the person, just as the thyroid medication is provided, and treating the things that are treatable. That's what you can do. So, what predicts schizophrenia? This is something that a lot of family members and a lot of doctors want to know as well. So with Dr. Borsman, we've done a study retrospectively in our adults. People want to know if my child has some sort of autism spectrum, does that predict schizophrenia? No. How about if they have a more severe level of intellectual disability, does that predict schizophrenia? No. How about a heart defect? A lot of doctors thought, oh well, if the heart defect, then they're put onto the heart-lung machine, they might have hypoxia to the brain, so low oxygen to the brain. No, not heart defects. How about hypocalcemia? No. Not predisposing to actual psychiatric illness, diagnosable psychiatric illness, no. Do mood and anxiety disorders, so does having a depression or an anxiety disorder predispose you to schizophrenia? No. Doesn't seem to be attention deficit disorder either, no. There are some genetic factors that we've looked at, none of those so far. But we have an international consortium that is really trying to answer this question. So we have a group, and you see the number, 22 international sites, just by coincidence, all over the world, 2 here in Spain, in Madrid and here, and in Mallorca, and we are together as an international group with as many patients as possible with 22q11.2 deletion syndrome. We are going to compare those with schizophrenia, those without schizophrenia as adults. What are the differences? What can we find? Genetic differences and other differences between those two groups. So we think by pooling our resources and putting an international effort into this very important question and other questions to do with, particularly with the neurocognitive side, this is funded by the National Institute of Mental Health in America, that we may be able to come to some answers. So this just started last September. So what do? You do standard management for each individual condition. And this is the same. For thyroid disease and 22q, what do? You treat with thyroxine, the same as you do for any patient. Okay? What do you do if it's a tetralogy of Fallot? You treat with the same surgery as for any person who's born with tetralogy of Fallot. So it's a standard management with some pluses. Okay? We do extra investigation and monitoring and anticipatory care in 22q11.2 deletion syndrome. We have to pay extra attention to possible medication effects and side effects because often the person has multiple different conditions, so you have to take those into account. The goal is always to maximize the functioning of the individual person. Family and caregiver involvement is critical. I think it is for any patient, but especially in 22q because the family is usually very involved with the person, and it's essential. And it's usually the family, sometimes also the person themselves, monitoring for those changes. Changes in thinking, emotions, behavior, changes in sleep, energy, that sort of thing, appetite. The parent or caregiver knows best, and Dr. Borsman really made that point earlier. And that you're going to seek help if there are concerns. So, I want to really emphasize the importance of an accurate diagnosis, and I think Dr. Borsman and I may also emphasize this. So it's signs and symptoms, and you see all these words, history. Okay, this is you giving the information, and so I think they had on their slide, listen. This is the listening part. This is what the doctor has to do, and I couldn't agree more that if your doctor is not listening to you, I don't care what specialty, you've got to find another doctor. That's for sure, okay? So we want to know the baseline and the best functioning so that we can get back there, or maybe even better than that. Social history and examination and treatment response and side effects, very important. So what about vocational functioning? Actually, I think Dr. Oscar's daughter is going to talk about this, but I will just say for adults, what we've found is that the majority of adults actually can do part-time work or full-time work. This is fantastic, especially if they have no psychotic illness. It's much harder if they have the schizophrenia, but we also have quite a chronic group of patients, so I think we can do better than these figures will suggest. But anyway, again, substantial individual variability with that. What predicts adult functioning? Of course, the intellectual level, that goes without saying. If the intellectual level is really quite low, well, then that limits the person's abilities in the end. Also the psychotic illness, but not congenital cardiac defect, so that does not limit the person's functioning. It was quite a striking finding. And not mood and anxiety disorders as long as they're treated. So these are not things that affect the adult functioning. Relative strengths are in daily living skills and employment. Work is good. The work that, again, is matched well to the person, just like education, excellent. People with 22Q, fantastic workers, really, really good. But a number of people, because they have various disabilities, perhaps for either medical reasons or psychiatric reasons, are on a fixed income, and about half of the patients that we follow are living with parents or relatives, even well into their adult years. But of course, that's quite common now in the general population too. So anticipatory care, again, multi-system disease. It's evolving expression. You have to keep an eye all the time out for changes. If the person is having abdominal pain and after fast food meals, so fatty meal, first of all, it would be better if they weren't having that, but anyway, that could be biliary colic, so that could be gallstones. So you have to you have to keep an eye on multiple systems. Targeted investigations and monitoring, we have the clinical practice guidelines. Now they're for children, and we're just in the process of writing up the first adults clinical practice guidelines for 22q11.2 deletion syndrome. But in the meantime, the pediatric ones are pretty good, and they're really multi-system. There's some out there on the table I saw. So that's really what we're following, and that's what every specialty, including the dentist, should have to look at. Standard management I just mentioned, but you have to consider the medical and psychiatric conditions altogether, extra attention to the side effects I already mentioned, and the family involvement. So, it's a growing population. Adults, okay, funnily enough, children grow up. So, most children with 22q deletion syndrome, and Donna made this point earlier, grow up. There's no problem with that. So they're growing up, so they're coming into this transition time, and so it's a very important time to be aware of. We have guidelines now for the anticipatory care. We want to maximize the functioning, and the genetic counseling then becomes very important. So this is for everybody with 22q11.2 deletion syndrome. We do genetic counseling, and we do like refreshers of genetic counseling, both for the parents and the caregivers, but also for the patients at every visit. So when they're coming, every 1 to 2 years, we just remind people about the reproductive risks, the 50% risk of transmitting the deletion, what we know now, which is every year is more and more about the associated conditions, and individualizing that to that person. And so we repeat this information about the genetic counseling over time. We talk a lot about partner choices and contraception. And we are looking at all of the factors, for example, the emotional outbursts, which I mentioned before, the fatigue, caffeine. I talk an awful lot about Coca-Cola and Pepsi-Cola. It's poison. Pop is poison for patients with this condition. Caffeine can drive the anxiety, the aggression, and the agitation in this condition. Of course, it disturbs sleep. So it's really, really, really bad. And it's particularly bad for hypocalcemia because the phosphates in it can drive the calcium level down as can alcohol. So it's trouble for their teeth, it's trouble for their stomach, it's just bad. Sometimes you may need to treat as well for the psychiatric illness, anti-seizure medications, but they're all available. There's a big range there as well. And again, just to make sure that you appreciate the other conditions. The individuals are the most important. You want to play to the strengths. You've heard this before. This is a theme, and it's the same for the adults. We want to support the relative weaknesses. Routine and structure always is a good thing for people. I think it's good for all of us, but it's really good for 22 people. Realistic expectations. For the arithmetic problems, carry a calculator for trying to do, if you need help with the counts and everything, somebody has to help you, then that's good. Being aware of the fatigue, usually patients need a bit more sleep than other people with this condition. Lots of reminders. Written reminders, pictures, way better than you tell them, and they know it. If they listen, is it going in one ear and out the other ear? Much better, but repeated reminders, you just have to live with it. That's this condition. You can trust the person, they get used to taking their own medications and they're really good with it, but you need to check. You just need to check and make sure that that's continuing on. that things are working well. Internet safety, I see that Sheila Cameron is going to talk about that, so that's really good. So we talked about all these things. You do have to take into account other things like hearing deficits. If the person isn't hearing properly, you can't say that that's auditory hallucinations. You have to make sure that their ears are checked, their ears are syringed, and that they're not agitated because they've got constipation, and the physical stresses, we talked about that. So there's lots of things to take into account with this condition. We have a clinic for 22q1.2 deletion syndrome. It's especially for adults, a multidisciplinary clinic that just opened last year. And we now can take international patients. Not that we've got lots of Canadian patients, so that's good, but we can do that. And I just want to acknowledge all of our patients and families and a wonderful set of students. So I'll stop there.